Hi everybody, Dr. Daniel, and today I'm talking about, do prescription drugs for migraine work better than the over-the-counter drugs? Migraine is a commonly present, disabling, oftentimes lifelong neurologic problem. You're born with it and it's in your family. For women, migraine is the most common medical problem, affecting 25% of all women and 6% of men. 12% of the world population has migraine. The next problem is what to do about it. Ignore it and just treat it when it comes up with over-the-counter drugs, or take a better thought out, more aggressive course and see a doctor and get on prescription drugs. Which method works better? Well, do prescription drugs for migraine work better than over-the-counter drugs? Over-the-counter drugs are mild analgesic painkillers and anti-inflammatory drugs. They have no specific remedial action in the complicated migraine process and only work on the pain part of a migraine. They're relatively cheap, since Advil, ibuprofen, 200 milligrams, 6 tablets is $6 in Dallas at Walmart. Over-the-counter drugs modulate pain but do not produce a headache-free experience. Over-the-counter drugs do not help with nausea. In fact, if too many of them are taken over a short period of time, they increase the acid in the stomach, producing symptoms of gastritis with pain and nausea. One of the 7 triptans taken at onset of a migraine interacts in the migraine timing cycle to stop the release of neurokinin A, substance P, and calcitonin gene-related protein, CGRP. Triptans act as agonists for serotonin 5-HT1B and HT1D receptors at blood vessels and nerve endings in the brain. Triptans enter into the physiology of the migraine process by blocking the release of the 3 neurochemicals that cause a migraine headache. Triptans give a headache-free experience for 70 to 80% of patients by 2 hours. Triptans treat all of the symptoms of a migraine, the severe throbbing pain, nausea, and sensitivity to light and sound. They are all generic now and have few side effects and are reasonably priced. 9 tablets of 100 milligrams sumatriptan costs $15, but you have to see a doctor to have one of them prescribed for you. They're not available over the counter. And triptans do not treat tension-type headache. Associated questions. What is a migraine timing cycle? It's generally thought that the local vasodilatation of intracranial extracerebral blood vessels and a consequent stimulation of surrounding trigeminal sensory nervous pain pathways is a key mechanism underlying the generation of headache pain associated with migraine. This activation of the trigeminal vascular system is thought to cause the release of vasoactive sensory neuropeptides, especially CGRP, that increase the pain response. The activated trigeminal nerves convey nociceptive, that means painful information, to central neurons in the brainstem, trigeminal sensory nuclei, that in turn relay the pain signals to higher centers where headache pain is perceived. It's been hypothesized that these central neurons may become sensitized as a migraine attack progresses. The triptan anti-migraine agents, such as sumatriptan, rizatriptan, zolmitriptan, naratriptan, and frovatriptan, are serotonergic agonists that have been shown to act selectively by causing vasoconstriction through 5-HT1B receptors that are expressed in human intracranial arteries and by inhibiting nociceptive transmission through an action at the 5-HT1D receptors on peripheral trigeminal sensory nerve terminals in the meninges and the central terminals of the brainstem sensory nuclei. These 3 complementary sites of action underlie the clinical effectiveness of the 5-HT1B/1D agonist against migraine headache pain and its associated symptoms. So the migraine timing cycle is as follows. 1, the trigeminal nerve is activated and cerebral arteries dilate. 2. At 20 to 40 minutes later, the neurochemicals CGRP, neurokinin A, and substance P are released by the migraine process from ganglia to inflame the trigeminal nerve, the arteries, and later the thalamus, which is our pain center. 3. At 2 hours, the arteries vasodilate and are inflamed. Blood pulsing through dilated, inflamed arteries causes pulsatile, pounding headache. And 4, past 3 hours, the thalamus, also known as the pain center of the brain, is turned on by the migraine process. I have a beautiful picture of this on my blog at drmigraine.com on this article if you want to see that. For most persons with migraine, taking a triptan at onset can give a headache-free experience at 2 hours. No other acute therapy drug can do this. Triptans for the past 30 years have been and still are the best drugs for acute therapy for migraine. Well, what about the new acute therapy drugs that came out in 2020? The triptans are all generic now and are cheap when compared with the new, I'm going to call them 2020 acute therapy drugs, which are all name brand and expensive. These drugs are Nurtec, Ubrelvy, and Rayvow. These new drugs are all delivered orally. Nurtec and Ubrelvy block the CGRP receptor, and Rayvow works on 5-HT1E receptors, which inhibit trigeminal nerve pain pathways. Rayvow also inhibits release of neurotransmitters and neuropeptides. These drugs do not work as well as triptans for migraine treatment. They could be tried for the 20 to 30% of persons who do not respond well to triptans and for migraine patients who have cardiovascular restrictions for use of triptans, like a post-myocardial infarction patient or somebody with out-of-control hypertension. However, advice for using Rayvow restricts the migraineur who takes Rayvow from driving or operating machinery for 8 hours after, which is a significant restriction. The drug causes drowsiness. How could a migraine patient working in an office treat their migraine at work and ever be able to drive home by dinner 8 hours? What drugs are meant by over-the-counter drugs? This list of drugs is usually divided into caffeine aspirin drugs, NSAIDs, which means non-steroidal anti-inflammatory drugs, and Tylenol. The names of the caffeine aspirin drugs are Excedrin, BC powder, and Vivactin. Caffeine aspirin drugs are mainly used to treat migraine headaches, caffeine for cerebral vasoconstriction, and aspirin for pain. The names of the NSAIDs are Advil, ibuprofen, Aleve, naproxen, Arudis, which is ketoprofen, Relafin, which is nambutone, Celebrex, which is coxib, Clenarel, which is Selenodac, Motrin, which is ibuprofen, naproxen and Anaprox, Indocin, which is indomethacin, Arudis, I see that named that twice, and Feldene, 20 milligrams. Non-steroidal anti-inflammatory drugs decrease pain and lower fever, and at higher doses decrease inflammation. The names of Tylenol are acetaminophen, and in England and the European areas are called paracetamol. Tylenol is a medication used to treat pain and fever. Could over-the-counter drugs aggravate the nausea that comes with migraine? All the over-counter drugs listed above increase the amount of acid in the stomach. I mean, aspirin is acetylsalicylic acid anyway, which can cause gastritis and aggravate a stomach ulcer or gastric reflux. Whereas triptans treat the nausea that comes with migraine in 80% of persons. Do all acute therapy drugs for migraine cause medication overuse headache? The International Classification of Headache Disorders, version 3, ICD-10, which is the so-called Bible for classification of headaches, states that medication overuse headache may develop from A, non-opiate simple analgesics over 15 days a month, like Tylenol, caffeine, or Advil. B, from triptans over 10 applications, a pill, subcutaneous shot, or nasal spray per month. And C, opiates or analgesics combined with barbiturates over 10 days a month. Barbiturates are like Fiorinol, Fioricet, Frenulin, Esjec, or generic butalbital, but there is no place for the use of opiate narcotics are butalbital for migraine, and these drugs are notorious for causing medication overuse headache. Caffeine is said by the American Headache Society to be the number one drug that causes medication overuse headache that most people are taking daily. Are there limits to the amount of drugs to treat the headaches? Well, the deal here is to limit all headache drugs, over-the-counters, and triptans to no more than 2 days a week. I say that all day long to patients. This usually means taking only one acute therapy drug at a time, and you can only do it 2 days a week. Like sumatriptan, you can take twice a day. You could take 100 milligrams at 8 o'clock, and you have to wait 2 hours. You could take another 100 milligrams at 10, and then you're through for that day. That's 1 day, and you can do it another day during that week. Persons who drink several cups of coffee a day and who have migraine are warned. Migraine causes the 3 neurochemicals to come out, and it takes 3 days for these neurochemicals to be metabolized to get from the brain, circulate through to the liver, to be metabolized, and then leave the body via the toilet. A transformation occurs if one continues treating with painkillers or headache medications more than 2 days a week. Then every time a person takes 1 cup of coffee or 1 Tylenol, that individual gets 3 more days of the neurochemicals to be released, and the headaches just keep coming on. This process in the brain is like putting lighter fluid on a charcoal fire. The fire, or the headache in this analogy, keeps burning until one stops using the lighter fluid. The reaction is exactly like this. What can you take for migraine headaches relief if you get medication overuse headaches, since that's such a common problem with them, like over-the-counters? There are other drugs to use for this, but patients need to work with a headache doctor for this type of treatment. One could use dopamine antagonists. The dopamine antagonist group consists of drugs which are usually indicated for psychiatric disorders such as schizophrenia or bipolar disorder. They may be used off-label for treatment for medication overuse headache. Off-label means the drugs work for another indication, like the drug works for schizophrenia, than the usual illness the migraine treats, the medication treats. So a drug for bipolar disorder would work for medication overuse headache. That's the idea. An off-label example would be that chlorpromazine is indicated for bipolar disorder, but also helps migraine. Chlorpromazine works for migraine patients because dopamine is a major brain neurochemical released during the migraine process, and blocking dopamine helps headache. This group of drugs may have a side effect of drowsiness. Dopamine antagonists may be used. Dopamine modulates processes involved in the migraine, such as nociception, which is pain, feeling, autonomic response, and vasodilatation. Dopamine antagonists also help with many of the symptoms of migraine, including nausea, vomiting, mood changes, and fatigue. Dopamine antagonists are appropriate for patients who do not respond to triptans. They should be limited to only 10 days per month. Examples of dopamine antagonists. Prochlorperazine, that's clombazine, can be given as 5 to 10 milligrams oral or rectally 25 milligrams. You can repeat it every 6 to 8 hours. And choose PRN for what's called status migrainosus, which is over 3 days of migraine headache. Prochlorperazine, thorazine, 25 milligrams orally every 6 hours to a total dose of 100 milligrams for cluster headache or refractory migraine. Droperidol, inositol intramuscularly, 2.7 milligrams, is highly effective for intractable migraine, but it can prolong the QT response on an EKG test and should not be used with any patient with heart disease. Haldol, haloperidol, 5 milligram IV, gives significant relief, or 2 milligrams to 5 milligrams oral drug can be used outpatient to abort a migraine. Continuing with a list of different psychiatry drugs here, prokinetic drugs agents can be used. The prokinetic drugs listed below are usually indicated for treating nausea or vomiting, but also help migraine. So we've got oral metoclopramide, which is Reglan, can be used 10 milligrams 3 times a day, or promethazine, which is Phenergan, can be given as 12.5, 25, or 50 milligrams every 4 to 6 hours. And then we've got atypical antipsychotics. Olanzapine, which is Zyprexa, can be used orally as 2.5 or 5 milligrams. Also, there's a 7.5, 10, 15, 20 oral dose drug can be used nightly for 5 to 10 nights to break status migrainosis. Quetiapine, which is Seroquel at 25 to 75 milligram orally, reduces headache frequency and severity and can be used as rescue medicine. Quetiapine may help with sleep and headache for treating medication of headache also. The most beneficial oral medication is olanzapine, followed by chlorpromazine. Or there's an NSAID here, Acute 60 milligrams IM, that's often used in the emergency room for acute onset migraines. You can give it every 6 hours. That's an NSAID, which may be given intramuscularly as an injection. And also there's a beta blocker eye drop, which is very successful. These work really well for a lot of folks. It's called Timolol, Timoptic eye drops, usually written 0.5% solution. There's 1 to 2 drops in each eye every 2 to 4 hours, PRN migraine. Beta blockers work orally for migraine prevention, like propranolol was the first drug really offered as a drug for migraine prevention by the FDA back in 1974, but they don't work for acute therapy. Yet some patients respond well to Timolol, which is a beta blocker given as an eye drop, and there's no rebound problem. I have an article on Timolol eye drops under acute treatment of migraine on my webpage. What's the difference between chronic migraine and medication of headache? These are both terms for the International Classification of Headache Disorders. So chronic migraine is a term that implies having headache over 15 days a month, 8 of which have migraine features. Migraine features there as being severe throbbing, one-sided, associated with nausea, vomiting, and sensitive to light. Those are the migraine features. Episodic headache refers to having 8 or less headaches a month. These migraine features are that the headaches are severe, usually one-sided, throbbing, associated with nausea. A significant number of these patients have medication-induced headache, which is now 80 to 90% of new patients seen in a specialty headache clinic, and that affects about 4 million people yearly. Medication-overuse headache may come from overtreating with simple painkillers like caffeine, Tylenol, or Advil, opiate narcotics, painkillers with barbiturates, or triptans. Patients typically rotate different drugs and take many drugs at the same time that may cause medication-overuse headache. After a while, presenting headache problem, which is usually migraine, but may also be tension-type headache, becomes transformed from an intermittent to a chronic headache problem. It's like what happens to a patient who drinks a lot of coffee every day and then gets a headache when they don't drink coffee. When the brain becomes sensitized to these drugs, repeat dosing causes neuroinflammatory chemicals to be released to the brain, which keep the headache going. And there are 2 features otherwise to medication-overuse headache. 1, the person will get daily or very frequent headache, which comes with sensitivity to light and sound, nausea, and irritability. And 2, the syndrome causes serotonin, a calming brain neurochemical, level to drop. So the patient may also develop anxiety, depression, poor concentration, panic attacks, and insomnia, which are core symptoms of medication-overuse headache. First, these folks need to learn that they're taking too many painkillers or headache medicines, that this causes or aggravates headaches. If you don't believe me, then Google medication-overuse headache from caffeine or medication-overuse headache from Tylenol or Advil and read what comes up. It's all over the place. If you have these problems, then when should you see a headache specialist? When headache is more frequent and severe and medical treatments have not worked or the diagnosis is uncertain, then it's time to see a headache specialist. When headache is disturbing your life, your work, your general health, and your sleep, it's time to see a headache specialist. Headache specialists have their own personal interest in headache. They like to read about it in scientific journals and books. They go to headache meetings. Many of them have migraine themselves, like 60%. During training, they may take a headache fellowship program. Because most headache patients a doctor sees occur in patients who are generally healthy and have a normal neurologic exam and test, like an MRI scan, headache doctors gain a lot of experience seeing the same kind of problem over and over. 89% of new patients to a headache clinic have medication-overuse headache, which is a syndrome due to overuse of painkillers. The doctor may hear that their patient used to have episodic headaches lasting 2 to 3 days. That's less than 8 migraines a month. But during the past 6 months, the headaches have occurred continuously and daily. The headache patient pattern may have migraine features also. Then on interview, the doctor may find the patient is drinking 4 cups of Starbucks coffee a day, which is a high level of caffeine, and taking tramadol, which a lot of doctors and patients don't know. They think it's an NSAID, but it's really a narcotic. It's an opiate narcotic for their headaches. And caffeine is the number one drug causing a headache, and tramadol, should never be used for headache. The doctor will do a careful neurologic exam on that patient, review or order tests such as blood work or CAT scan or MRI scan, and the rest of the interview will be educating that patient that needs to stop caffeine and tramadol either suddenly or slowly by tapering off. Then the doctor will substitute treating this daily severe headaches with 1 to 2 weeks of cortisone, which usually helps, like prednisone. And they should start a preventive drug like one of the new CGRP drugs, and offer an acute treatment drug like Timidol or eye drops or DHE, which don't cause medication-induced headache until the patient clears up, and then they can use a triptan and their CGRP preventive drug. At this point, you could go to my website at drmigraine.com/medication-induced headache and read my full article on medication-induced headache. It's the one with the frowny face made up of pills. There are concerning symptoms or red flags that should provoke a patient to see a headache specialist in the clinic or to go to the ER. These symptoms may be complicated headaches with unusual symptoms, feeling weak or numb on one side of the body, change of level of consciousness, trouble walking, change in memory, vision, or ability to speak, having a migraine longer than 72 hours, persons with complicated medical or psychiatric problems, such as patients with fibromyalgia, asthma, epilepsy, insomnia, anxiety, depression, or panic disorder. Having headaches more than 2 days a week is worrisome. That's going to go worse, usually. Headaches that make you miss social events, school, or work. Headaches that affect relationships with family, friends, or coworkers. Headaches occurring while pregnant or nursing. Thunderclap headache, which is very severe sudden onset headache. It reaches its maximum intensity within a couple of minutes. Thunderclap headache require emergency medical evaluation to rule out intracerebral aneurysmal bleed. These headaches are, quote, the worst ever explosive, like something ruptured in my head, end quote, type headache. Positional headache, headache that substantially changes in intensity associated with changes in position, such as standing from lying or vice versa. Exertion-related headaches, headaches from straining at the stool, sneezing, or coughing. New onset headache, especially if the patient are over 50 years of age or there's another medication condition like cancer or blood clotting disorder. A documented change in headache occurrence, such as an increase in frequency or change in headache characteristics. Constant headache, which is always on the same spot in the head. Migraine with aura patients have long or quick onset aura symptoms. Migraine aura symptoms may be the visual aura, which may be a bright light or zigzag image. Numbness in one side of the body, which starts the fingers, next move to the forearm, then the arm, then commonly to the one same side of the body, face or cheek. Migraine with aura patients may also have trouble speaking, called dysphagia, where they cannot find the right word to say and they cannot read or write well. The progression of these aura symptoms should have a slow onset and resolve within 60 minutes. But if they do not improve in an hour, emergency medical attention isn't required, with a visit to the ER and emergency scanning to rule out a stroke or brain tumor. I'm still on the list of concerning symptoms that should get you to see a doctor. Headaches that never go away. Headache plus systemic symptoms such as fever, chills, weight loss, or night sweats. New headache in a patient with cancer. That could be a MET to the brain, metastatic lesion of the brain. Headache that keeps getting worse over 24 hours. Headache after head injury. Headaches that come with visual blackouts, pain while chewing, body arthritis, or weight loss. That's all temporal arteritis. All right, well, what about taking a preventive medication? So when to start preventive medication? Preventive medication may be called daily treatment or prophylactic treatment. It means that the doctor intends his patient to take a daily drug to reduce the intensity and frequency of the patient's migraine headaches. This is really a drug trial. When it starts, the patient should be asked to log their headaches in a diary and use the drug for 6 to 8 weeks to judge results and improvement or no response for their migraine headaches before giving up. A lot of people want to take it 3 weeks and stop. Well, it's just done long enough. So when do you start preventive therapy for migraine? It should be considered for patients who experience 3 or 4 migraines per month, patients who have chronic migraine defined as 15 headache days a month, patients who present with medication of his headache, who prefers this type of treatment, really, patients that have significant pain that hampers their life, patients who take a lot of over-the-counter narcotic, opioid, or barbiturate painkillers, and patients who don't get relief from the acute treatment medication they're currently taking, patients that have side effects from drugs used for acute therapy. Preventive treatment might not be an option for patients who can control their headaches with anti-inflammatory drug NSAIDs like naproxen and ibuprofen, patients who have other health conditions that do not allow them taking preventive drugs. A patient may already be taking drugs who would not mix well with any proposed preventive medication they might take. Patients who prefer treatments that do not involve taking medications, such as they can get release from exercise, relaxation therapy, stress management, or biofeedback. Patients who prefer a medical device called Cephaly, which is a FDA-approved treatment for migraine prevention. It's worn on the head, delivers a small electrical impulse that's used once a day for 20 minutes. Patients who are pregnant, as migraine usually improves in the second or third trimester of pregnancy. Most OB doctors allow their pregnant migraineurs to use Tylenol, and neurologists allow triptans and CGRP drugs when needed during pregnancy. So what is to be done? What's this talk about? Should we take an over-the-counter drug or prescription? I must admit to having been a neurologist and a headache specialist for over 40 years, and I would answer, see a doctor and start prescription medication for migraine. If the migraines occur more than 3 or 4 attacks per month, consider one of the CGRP preventive drugs. Consider this. Most persons with very mild migraines, they take 2 aspirin and take a short nap. They go to sleep, and they're not spending their time reading web articles about treating migraine because they don't need to. Their migraines are not very severe, and they're living with their what they call hungry headache, menstrual headache, sinus headaches, which are really migraine. Very well, thank you, and they do not need to see a doctor until or if they develop medication overuse headache sometime in their lives. However, persons who are having migraine attacks more than 3 or 4 days per month are skirting on the edge of medication overuse headache, and a sit-down visit with a regular doctor might discover this risk. I usually ask the patient also, quote, what's the usual time between onset of your migraine and the peak? It is said that over-the-counter drugs work better for migraineurs with long, like 60 minutes onset to peak migraine onset times. If it's a short time, then short-acting triptans like 6 milligrams subcutaneous sumatriptan or 5 milligrams zomatriptan nasal spray, which both work in 10 minutes, are preferred. Playing the triptan game, one wants to get medication in the patient's brain before the neurochemicals are released. That's what it's all about. Many persons have it in their heads they do not want to take a daily preventive drug, and I understand that, particularly with the older drugs that we use, such as amitriptyline, topiramate, Depakote, and propranolol, which have track records of only preventing migraine about 30% of the time. They work, but not that well. However, the new CGRP preventive drugs mentioned above are something else. They do require a subcutaneous injection, but it's given only once a month. And remember, type 2 diabetics get 4 shots a day unless they're on an insulin pump. It reminds me of the resistance of the conversations I've had with younger adolescents or sometimes teenage migraine patients who could not even swallow a pill. Subcutaneous shots, no big deal. The situation with the new CGR preventive drugs is that they are rare. They have rare, mild side effects, and they work so very well. It's amazing. 50% of migraine patients on one of those drugs get 50% attack reduction. Another 25% get 75% migraine reduction, and another get 25% get complete 100% migraine reduction. Wow! I've seen many patients in this no migraine attack group, and I recall that these patients had all been persons dealing with long-term migraine for much of their lives. The question of cost of CGRP presents itself. They are more expensive, and many insurances require the patient to fail previous treatment with one of the older preventive drugs before they let them start it. Although the pharmaceutical creators of the new CGRP drugs, such as Eli Lilly, Teva, Amgen, and other drug companies have aggressively marketed CGRP medications and even given the drugs away at the beginning for free to get people to try them. Sales growth has been slow. Only Aimovig and Emgality are used by at least 10% of migraine patients, and this is a sad treatment experience from my point of view, considering how prevalent and how disabling migraine can be. I've heard that if a person has no medical insurance also, but submits their financial data to one of the large pharmaceutical firms, they may be able to get the medicine for free. This situation requires the patient work with their doctor, which would likely be more successful if their doctor were a headache specialist, because the pharmaceutical drug maker usually mails the free prescription to the doctor's office to pick it up. So thanks very much for listening to me. Best of luck to all you patients with headache and migraine, and I'll see you again on the next talk.